Hi medicos, welcome to my YouTube channel, Indian Anatomist. I hope all are doing well. Today I am going to discuss the mammary gland. Before going to the topic, this video has adult content. This is an educational video that may contain disturbing content. Some viewers may find the following video disturbing. Viewer discretion is advised. What is the mammary gland? The mammary gland or breast or mamma is a modified sweat gland present in the superficial fascia of the chest region. It is a bilateral structure present in the pectoral or chest region of both sexes. Normally in males and immature females, the mammary glands are rudimentary, and the nipple is small, but the areola is fully formed. Premature theliachy is a medical condition characterized by isolated breast development in female infants. It occurs in females younger than 8 years. After puberty in females, the mammary glands are well developed and well marked during pregnancy and lactation. The shape varies in adult females, which may be hemispherical or conical with a pendulous structure, with a circular base remaining fairly constant. With this brief introduction, we will see the anatomy of the mammary gland. Now, what is the extent of the mammary gland? In humans, each gland is vertically extended from the second to sixth rib at the mid-clavicular line. Horizontally, it extends from the lateral border of the sternum to the mid-axillary line. The upper lateral part of the mammary gland shows a small extension called the axillary tail of Spence. Please see the illustration. This tail enters into the axilla through a deficiency present in the axillary fascia, or deep fascia of the axilla, is called the foramen of Lange. Each mammary gland lies over the following structures in the pectoral region. They are 1. Medially to pectoralis major muscle. 2. Laterally to the serratus anterior muscles. 3. Inferiorly related to the external oblique abdominis, and 4. To a small extent on the medial aspect, it is related to the rectus abdominis muscle. All the above-mentioned structures are collectively called the mammary bed. Next is retromammary space. This is an important space present between the base of the mammary gland and the pectoral fascia that covers the pectoralis major muscle. What is the purpose of this retromammary space? Because of this space, the gland moves freely over the pectoralis major muscle. During carcinoma or CA of the mammary gland, the gland is fixed to the pectoralis major. Now I will discuss the features of the mammary gland. Please follow the illustrations provided for your better understanding. The first feature is the nipple. It is a surface conical or cylindrical projection situated slightly below the center of the mammary gland. In nulliparous women, the nipple is present at the level of the fourth intercostal space to the midclavicular plane. The dotted line indicates the midclavicular plane. Each nipple contains 15 to 20 openings of the 15 to 20 lactiferous ducts that are surrounded by circular and longitudinally oriented smooth muscles. The circular smooth muscles erect the nipple during suckling, and the longitudinal smooth muscle retracts the nipple. The second feature is the areola. The areola is a circular area of skin around the base of the nipple. The areola is permanently darkened after the first pregnancy. The outer margin of the areola contains several modified sebaceous glands, which are enlarged during pregnancy and lactation, and are known as the Montgomery tubercles or glands. The secretion of the Montgomery glands provides lubrication during lactation. Dear medicos, please note that the skin of the areola and nipple is devoid of hair and subcutaneous fat. Now the third feature is the parenchyma, representing the secretory portion of the gland including the ducts. The mammary gland belongs to the tubuloalveolar or acina type of the parenchyma. Approximately the mammary gland contains 15 to 20 lobules. Each lobe is further divided into smaller units called lobules and releases the milk into the lactiferous ductules. All the ductules converge to form 15 to 20 lactiferous ducts that open into the surface of the nipple. Before entering into the nipple, each lactiferous duct has a small dilatation called the lactiferous sinus, which acts as a milk reservoir. The last feature of the mammary gland is the stroma. The stroma is the connective tissue part of the mammary gland which supports the parenchyma, or glandular tissue. This general connective tissue connects the overlying skin and underlying pectoral fascia. In addition, there are numerous linear strands of special connective tissue called suspensory ligaments of Cooper that connect the skin and the pectoral fascia. Its function is to anchor or suspend the gland on the chest region. Students, please see the animated image showing the suspensory ligament. Any weakness or reduction of the suspensory ligament of Cooper makes the gland sagging or no movement respectively. The stroma also contains enormous amounts of interlobular fat that gives shape to the mammary gland. Dear medicos, now I am going to discuss the structural differentiation of the mammary gland. From birth to prepubertal life, the gland contains lactiferous ducts, but without alveoli, the secretory portion. At puberty, the lactiferous ducts undergo repeated branching and terminal branches, forming a solid spheroidal mass, the alveoli. During pregnancy, the number of alveoli is increased. At around 6th month of pregnancy, the parenchyma increases and expands further due to increased blood flow and the presence of milk. During lactation, the first milk, or colostrum, secretes for a few days after delivery and is rich in immune globulins. The true milk secretes after a few days because of the suckling of the newborn. After lactation, when lactation ceases or after 6 months, the alveoli usually shrink, and the glandular tissue or parenchyma returns to the resting phase. Dear students, exactly what influences mammary gland development and growth? No doubt, the hormones. Estrogen stimulates the growth and branching of the ducts. Progesterone stimulates the alveolar formation at the ends of the branching ducts. During pregnancy, the placental estrogen and progesterone form the true secretory alveoli. After parturition, the maternal oxytocin helps in milk ejection, initiated by the suckling reflex. The circulating maternal estrogen in newborn glands secretes fat-free milk-like fluid from the nipple called witch's milk. Dear students, I have discussed about the gross anatomy of the mammary gland. The next part of studying the mammary gland is blood supply, nerve supply, lymphatic drainage, and finally the clinical anatomy. Now coming to the blood supply of the mammary gland. The gland is richly supplied by many arteries that come from superior, medial, and lateral glandular branches. The upper part of the gland receives glandular branches from the superior thoracic and thoracoacromial arteries. Both are the branches of the first and second part of the axillary artery respectively. The medial part of the glands receives medial mammary branches from the second to fourth anterior intercostal arteries from an internal thoracic artery. The lateral part receives lateral mammary branches from the lateral thoracic artery branch of second part of the axillary artery and second to fourth posterior intercostal arteries. Now we'll see about the venous drainage of the mammary gland. The veins of the areola, also called circulus venosus, are radiating veins that drain into the axillary, internal thoracic, and intercostal veins, whereas the residual glands veins drain into the intercostal and azygous veins, which may link to the vertebral venous plexus of Batson that presents in the vertebral or spinal canal. The glandular veins also have venous communications with cerebral, clavicular, and humeral veins. Knowing these connections is very important because retrograde venous flow can spread mammary gland malignancy to these bones. Hope you all understand about the arterial supply and venous drainage of the mammary gland. Now we'll discuss the nerve supply of the mammary gland. Because the mammary gland is a skin appendage, the skin of the mammary gland is supplied by anterior and lateral cutaneous branches from T2 to T6 thoracic spinal nerves and supraclavicular nerves. The smooth muscles and blood vessels of the nipple are supplied by the autonomic nerves. Dear students, please keep in mind that the nerves do not control the secretion of milk. It is controlled by the hormone prolactin, secreted by the pars anterior of the hypophysis cerebri, or pituitary gland. Next is lymphatic drainage and lymph nodes of the mammary gland. This is a crucial part of reading the mammary gland. The lymphatic drainage is clinically significant because the carcinoma of the mammary gland spreads or metastasizes mostly through these superficial and deep lymphatics to the lymph nodes. The superficial lymphatics drain the skin over the mammary gland, whereas the deep lymphatics drains the parenchyma, areola, and nipple. Now let's know about the lymph nodes that drain the mammary gland. 4 different types of lymph nodes drain the gland. They are: Number 1 is a parasternal, or internal mammary group of lymph nodes that drain 20% of the lymph from the gland. On the other hand, 75% of the lymph from the gland is drained by the axillary group of lymph nodes. These nodes are further grouped into anterior, posterior, lateral, and central nodes. All these nodes finally drained into the apical group of lymph nodes. The apical group drains into the supraclavicular group of lymph nodes. The remaining 5% of lymph drains into the posterior intercostal lymph nodes. There is a lymphatic plexus ring situated around the areola called the subareolar plexus of Sappi. The Sappi's plexus is important for identifying the sentinel lymph node. A radiotracer or dye is injected into the subareolar root, which is the easiest way to infiltrate the lymph nodes. Most of the lymph from the breast drains into the axillary group of lymph nodes, whereas the deeper part of the gland reaches either apical lymph nodes or internal mammary lymph nodes. Dear medicos, before discussing the clinical anatomy of the mammary gland, I want to discuss the development of the mammary gland in short. As we all know, the mammary gland is a specialized epidermal appendage, develops during embryogenesis, but finishes during lactation. The primary mammary-specific progenitor cells appear at 4 to 6 weeks of gestation. In humans, the thoracic epidermis epithelial cells proliferated in pairs at 35 days of gestation. These proliferative sites produce right and left ridges called mammary crest, or milk lines, or lines of Schultz, that extend from the fetal axilla to the inguinal region. The secondary mammary tissue starts to develop and forms a pit. These tissues develop and subdivide to generate gland lobes. Lobes and ducts are solid until canalization forms the channels. Nipple everting occurs at the pit site after birth. The estrogen, progesterone, and prolactin control the mammary gland functions. The important clinical anatomy of the mammary gland is carcinoma, which is the most common cancer in females. Physicians and surgeons divide the gland into 4 quadrants according to the clock position to locate the tumors. Mammary gland cancer can disrupt lymphatic drainage, causing nipple deviation and a thicker leather-like skin texture with large dimples called the Peau d'orange sign. Please carefully see the images. The larger dimples are to cancer invasion of the glandular tissue and fibrosis resulting in shortening of the suspensely ligaments. Due to cancer, the subareolar mammary gland causes inversion of the nipple. If carcinoma of the mammary gland is suspected, the clinicians advise the mammogram to the suspected patient. Mammography is a radiographic examination used to detect breast lumps. A cancerous growth appears as a rough, significant density on a mammography. Surgeons utilize mammography to guide the removal of breast tumors, cysts, and abscesses. Next is mastectomy. Mammary gland excision, called mastectomy, is less prevalent as a treatment for breast cancer. The mammary gland is removed from the retromammary area. The radical mastectomy entails removing the breast, pectoral muscles, fat, fascia, and as many lymph nodes as feasible in the axilla and pectoral region. Modern lumpectomy or quadrantectomy is a breast conservative surgery. A large local excision removes only the tumor and surrounding tissues, followed by radiation therapy. Men account for 1.5% of breast cancers. The cancer typically spreads to axillary lymph nodes, bone, pleura, lung, liver, and skin, as in women. Breast cancer affects over 1,000 males annually. Finally, what are polymastia, polythelia, and amastia? Polymastia means supernumerary mammary gland present along the mammary line or ridge. Polythelia means supernumerary nipples may be superior or inferior to normal nipples. It is commonly mistaken for a mole. Finally, amastia means the absence of mammary glands. Dear students, I am concluding this lecture. Please read well about the mammary gland, because frequently asked questions in examinations. Hope it will be an interesting video for you. I will meet you once again in another video. If you like this, please subscribe to my channel, Indian Anatomist, and click the bell button to receive notifications for new videos. Good day.